Thank you so much, sir. So, I'll be talking today about the lymphatic vessels in the complications of liver disease. So, we all know that lymphatic vessels are running parallel to the blood vessels. And just to begin, the traditional view of cirrhosis progression and complications, it revolved around the peripheral arterial vasodilation or the splanchnic vasodilation theory, but which included the compensated cirrhosis being increased when you have an increased splanchnic vasodilation. At this stage, you have an increased cardiac output, which actually maintains effective arterial functions, and you have preserved kidney functions. But if it increases further, the vasodilation, then the cardiac output doesn't increase further, and then you have all renal dysfunction, the activation of the RAS system coming into place. Now, this view actually doesn't resonate with many or doesn't explain many complications of cirrhosis. Like the circulatory dysfunction is progressing at one place, but the renal dysfunction, circulatory dysfunction is showing no progression, but the renal dysfunction is progressing. Then in this view, we do not have any explanation for multiple organ dysfunction, which is a common finding in cirrhosis. So there's a new hypothesis beyond peripheral arterial vasodilation, which is known as the systemic inflammatory syndrome. And according to this view, all of the complications of cirrhosis, they actually share a common pathophysiology, which is systemic inflammation. And we all know that there can be sterile inflammation without the infection component, like in acute hepatitis or in alcoholic hepatitis, and there can be an infection component, which we call as sepsis or severe sepsis. Now, the experts, they have actually put this course of cirrhosis progression into two phases. One is the low-grade inflammation and one is the high-grade inflammation. When we talk of low-grade inflammation, we also have a concomitant cirrhosis-associated immune dysfunction in that particular organ. And this low-grade inflammation or immune dysfunction may be followed by some episodes of acute decompensation in some patients, and more the episodes of these acute decompensation, you have more chances or a faster progression to organ failure or a high-grade inflammation. So now the major pathological driver of this systemic inflammation comes from the intestinal microflora by bacterial translocation. Now, bacterial translocation is normally a physiological process, but we all know that in cirrhosis it increases because there are physical disruption of the barriers, there's a growth of intestinal bacteria, and then there's a suppression of the immune defense of the gut. And excessive bacterial translocation or systemic inflammation also contributes to systemic hemodynamic abnormalities or circulatory dysfunction. Other causes of systemic inflammation include sterile inflammation and overt bacterial infections, which we just talked. So, according to the grade of bacterial translocation, we can also grade the severity of cirrhosis or the complications. With moderate bacterial translocation, we have no organ failure, we have just a moderate vasodilation. With more significant bacterial translocation, this worsens, and with severe bacterial translocation, we have organ dysfunction, we have renal failure, and then finally ACLF or acute on chronic liver failure. Now, what I'm going to talk is that a dysfunction in the hepatic and extrahepatic lymphatic system is actually one of the key factors which is influencing systemic inflammation, bacterial translocation, and some of the complications in cirrhosis. Let's see how. So, if I talk of hepatic lymphatic system, so hepatic lymphatics, the lymph formation takes place from the sinusoidal lymph, and there are three pathways of drainage. One is from the portal area, other is the hepatovenous area, and then you have the surface or the subcapsular lymphatics. And 80% of the lymphatic vessels in the liver are in the portal area, so we can call it as a portal tetrad. Now, the lymphatic vessels in the portal areas, they are clearly visible. They have single line channel of lymphatic endothelial cells, which have expression of podoplanin or LYVE1. And like other lymphatic vessels, their main job is immune cell trafficking and trafficking of lipids and proteins. Now, in the disease, it has been shown in a model of high-fat, high-cholesterol diet that the lymphatic vasculature in the lymph increases. So you see the density increases, you see the proliferation increases, but the functional expression of some of the markers, it decreases. When I say function, it has been shown that the drainage of the lymphatic vessels also decreases. This has been done by seeing a drainage of Fitzy dextran and then measuring its drainage in the portal lymph node. So if you see the green and the red bar, so it decreases in the high-fat, high-cholesterol diet. But this drainage can be rescued if you give a vascular endothelial growth factor, which is a pro-lymphangiogenic factor C. So this drainage is restored. Now what else is restored is the inflammation. So you have an increased inflammation in the model, but when we give VGFC, this inflammation comes down. And in this study itself, they have shown that even without liver damage, if you just give oxidized LDL, this drainage is similar to this model. The lymphatic drainage is reduced as compared to the controls, and this they showed is because the oxidized LDL directly affect the permeability of these lymphatic endothelial cells by enhancing the VE cadherin, which is a protein which is involved in the permeability of the vessels. So the study identified oxidized LDL as one of the major contributors to decrease lymphatic permeability, drainage in the liver, and this change leads to increased inflammation. And if we improve the functions of the liver lymphatics, it can reduce hepatic immune dysfunction and the inflammation. Coming to extrahepatic lymphatic vessels, I'll talk about gut in terms of ascites and the brain in terms of hepatic encephalopathy. Now, gut lymphatics, we all know they are the second route to systemic circulation. They bypass the liver. They start, vessels start as lacteals in the small intestine, followed by collecting vessels, and then there's a mesenteric lymph node, and which drains all the fluid from the intestine to the thoracic duct and finally to the system. So gut and liver, yes, both contribute maximum amount of abdominal lymph into the systemic circulation. So if we see ascites in terms of the lymph imbalance theory, which was given in 1980s, so we know that there is an increased production both in the liver and in the digestive tract. This increase leads to an increase in flow of the thoracic duct lymph. Now, till the time when this increased production of lymph is balanced by the removal of the lymph from the intestine or the liver, there is no ascites. But as soon as the lymph formation exceeds lymph absorption, it leads to a maldistribution of this extracellular fluid, activation of the kidney RAS system, the ADH, leading to sodium and water retention, increase in plasma volume, and thus clinical ascites happens. Now, another important point here to consider is not only lymph absorption suffers, but there is an increase in the diameter of the thoracic duct. So there was a study which showed that if the diameter of the cisterna chyli, which is the point where the thoracic ducts originates, it increases greater than 5.4 millimeter, the diameter of the thoracic duct increases greater than 3.7 millimeter, it includes clinically significant portal hypertension. And the point is that in more advanced cirrhosis, there is an increase in thoracic duct pressure. You actually have a narrowing of the junction of the lymphovenous part. So you have a lymphovenous junction narrowing in some of the patients with advanced circulatory dysfunction. So in this paper, they have treated such two patients by doing a stenting of the thoracic duct. So I'll not take more details, but just to say that by putting a stent of 6 millimeter diameter, the patients who had refractory ascites, because of the lymphovenous narrowing, the ascites decreased by almost half, and it completely resolved within 6 months without any additional interventions, suggesting that if we improve the lymph outflow in the thoracic duct, it can be really valuable for patients with advanced refractory ascites. Now, what is the mechanism of reduced lymphatic drainage? So this paper talks about the eNOS activity in the intestinal lymphatic endothelial cells. So it says that in cirrhotic models, the endothelial nitric oxide synthase activity, thus the production of nitric oxide, increases considerably. And if you treat these animals with an eNOS inhibitor, it actually improves the smooth muscle cell coverage in the collecting vessels. So if it improves the collecting vessels coverage of the smooth muscles, there's a good lymph propulsion and the ascites is completely resolved. Next, we wanted to study what are the status of duodenal or intestinal lymphatic vessels in the patient. So for this, we designed a study with healthy controls, compensated and decompensated cirrhosis, and then studied lymphatic vessels as podoplanal positive lymphatic vessels in the duodenal biopsies, and we scored them based on their intensity and density. So if you see, the podoplanal score was almost negligible in compensated cirrhosis, although higher than the controls, but maximum podoplanal scores, that means we have a high number of dilated podoplanal positive vessels in decompensated cirrhosis, and importantly, all these vessels were higher in patients with complications having ascites and bleeding. And another important point, that the podoplanal score was positively correlated not only with the intestinal inflammation but also with systemic inflammatory markers like TNF alpha and IL-6. So we went further, designed an in vivo study with animals using CCL4 and thiazidamide. So we used two models, one where we improved the lymphatics by giving VGFC, another where we inhibited the lymphatics by giving an inhibitor called as saroglitazar. So this SAR actually, when we, if you see the CCL4 vehicle models, this was the lymphatic diameter was dilated, the drainage was reduced, but the leakage was increased. But when we gave VGFC, the drainage improved and the leakage reduced. When we inhibited this with the SAR inhibitor, you see here the VGFC, as compared to the VGFC, the drainage was completely reduced and the leakage was increased, suggesting that lymphatics, if improved, will improve the leakage from the lymphatic vessels in cirrhosis. And if you see here, when we gave VGFC treatment to these animals, the abdominal ascites almost significantly reduced, suggesting that improved lymphatic drainage can lead to an improved ascites. Now, I just talked about mesenteric lymphatic nodes. So if the gut vascular barriers are intact, there is no bacterial metastasis. So the major work of the lymphatic nodes is to prevent the spread of the bacteria. But what happens in advanced cirrhosis? We can see viable bacteria in the lymph nodes. So this viable bacteria and systemic inflammation goes hand in hand. So it means that the systemic inflammation comes from the mesenteric lymphatic nodes in advanced cirrhosis. So in our models also, we could see a lot of bacterial load not only in the mesenteric lymph nodes, but also in all other organs like liver, pancreas, spleen and lung. And when we treated these models with VGFC, improved the lymphatics, the bacterial load reduced, whereas when we inhibited this model with the using the lymphangiogenic inhibitor, this bacterial translocation increased, suggesting the role of intact lymphatics in controlling bacterial infections. So VGFC also reduced local and systemic inflammation. You can see that with VGFC, endotoxemia in the ascites reduced, and also serum IL-6 and TNF alpha reduced in the blood. So we can say that improved gut lymphatic dysfunction increases drainage, reduces ascites, limits bacterial translocation, and in fact also systemic inflammation. Coming to my last part, systemic inflammation and HE, we all know that both systemic inflammation and hyperammonia are a double hit to the progression of hepatic encephalopathy, and if both are present, it can lead to more adverse outcomes. Now, what is the link? There is a brain lymphatic system, which is the glymphatic system, which links inflammation and HE. So it is nothing but a perivascular space which is draining all the metabolic waste from the brain. And actually systemic inflammation, it impairs the lymphatic system in the brain, leading to neurodegenerative disorders, thus which also leads to inflammation. So it forms a vicious circle, and in hepatic encephalopathy it has been clearly shown that there is a decreased lymphatic clearance or decreased meningeal clearance in the brain due to the decreased expression of a protein called as aquaporine proteins. And this leads to more neuroinflammation and motor function reduction in hepatic encephalopathy. And if we give a local injection of VGFC, that means we improve the lymphatic function in the brain, it can increase lymphatic drainage and decrease neuroinflammation and improve motor function. But this is only an animal study. We don't know whether lymphatic function or dysfunction is happening in the patients of HE or not. Take home message, lymphatic dysfunction in the liver leads to impaired immunity and increased hepatic inflammation. If we have a gut lymphatic disorder involved, there will be an aggravation of ascites, bacterial translocation, leading to systemic inflammation. Along with that, brain lymphatic dysfunction we know will worsen neuroinflammation and thus neurocognitive functions and thus HE. So a compensatory but insufficient increase in lymphangiogenesis with dilated and dysfunctional happens not only in the liver but everywhere in other organs in cirrhosis. But this is, as I said, insufficient. So we need to restore lymphatic functions either by VGFC or other treatments that can reduce bacterial translocation, organ dysfunction and systemic inflammation. So I believe that targeting lymphatics has an immense potential to manage ascites and other complications of cirrhosis. So this is my team and my acknowledgements to Professor Sareen, Dr. Shastri and Dr. Archana. Thank you so much.